Everyone, I just wanted to let you know we are now in our next session, which is residence rights. Okay, so today, I should say in this video, we're going to be covering multiple items. We're going to go over our policy and procedure on what resident rights are. We're going to look at the actual CDPH guidelines for our residence rights admissions packet. And then we will be going over our PowerPoint within regards to residence rights. Now, there will be a post test that you will take when you come in for your um, in-person training, so to speak. And so all this content that we cover today will be the information that you need in order to pass the exam on the subsequent days. So without further ado, I'm going to start a little bit differently. Instead of with the PowerPoint presentation, I'm going to go over uh, our policy real quick. That got out of control. Okay, now let me open up my Zoom and I'm going to share a window. Okay, so everyone should be looking at policy PC9. It's a 3-page document. And the subject inside our policy and procedure manual, and when you see PC, that stands for patient care. It's just an easier way for me to track the policy and procedure manual. So the subject matter of this is discharging of residents, discharge planning, discharge criteria, and termination of services. We also discuss patients that want to leave against medical advice. So the purpose of this policy is to establish a procedure for resident discharge termination from within GOL. A resident will not be discharged based on race, color, religion, ancestry, or national origin. The criteria for discharge for a reason other than death may include the resident's condition has improved to the extent that the patient is no longer appropriate for our care. That would be best case scenario. The family desires to take the resident home and adequate plans have been established. Awesome. The resident and family or attending physician requests discharge or transfer to a different facility or level of care. So on that one, higher or lower. If the patient's condition is worsening and we're doing everything we can to improve them and the family wants more extenuating measures done, we're going to transfer them out to the hospital or to the next appropriate level of care. We may take them to another facility. Maybe they no longer meet criteria at the cliff. We have other categories of this that we may discharge the patient almost as like a reprimand, right? So if the resident and or family behave in a way that compromises the safety of themselves or others. We've talked about in our other videos that we've had thus far is that it's our job to provide a safe environment. We can't have a particular patient causing harm to other patients or harm to our staff because our staff is very valuable to us. Some of those categories might be the person using illegal drugs or consuming alcohol to the point where they're getting physically violent or just unacceptable behavior. The resident may want to go to a new facility. That's what we see there in number 5. Number 6, the failure to pay legally incurred fees and other reasons may be determined by the administrator. That's myself. And absolute worst case scenario for us is that our facility shuts down. That would be the reason why we would have to discharge them. So our procedure starts with the licensed nurse, ensures that a resident or the responsible party are informed of the scheduled discharge and are included in the development of a plan. We coordinate community resources that may be needed post-discharge. We'll obtain an order for discharge from the attending physician or designee specifying the destination of the resident and the date of discharge, and there will be a written discharge summary. This document will be inside the patient's health record, and we will be disposing of whatever remaining drugs we have here by the appropriate procedure that we have. We will complete the documentation that's needed for the coordination of care. The resident's going home, the nurse will need to provide written instructions, including medications and physician follow-up. A resident is transferred to another facility, a nurse will provide a copy of the discharge summary. For residents going to an acute care hospital, the nurse will call a verbal report to the receiving unit prior to discharge. It's very important that our staff does nurse to nurse, right? Just like we have physician to physician. So on an unexpected discharge, the nurse will assess the resident's situation, determine the risk to staff and other residents for continued stay. Serious and immediate risk, we're calling 911. And that may be to protect self and residents to the degree that's possible. If there's a risk where the patient is causing harm to the people or the property, if it's causing harm to people, if he or she's causing harm to people, we're calling 911, right? But if it's the physical property, you guys got to let me know. Damaging the walls, stuff like that, breaking windows. Low risk of harm to people or property, just monitor, notify myself as well, notify the family and assess for ways that we can. What I'm going to do is I'm going to determine the course of action. I'm going to develop a signed contract with the resident that states specific parameters that must be maintained or risk termination of services. And if you guys are curious on what I would do with the termination of services, I'll notify the resident, family, and physician by telephone or by letter as appropriate to the specific case. Written notification is appropriate when termination is not agreeable due to the physician, or I'm agreeable to the physician, the resident, or the family. I'll determine a reasonable amount of time for advance notice of termination of service being given to the resident. I'll assist the physician, the resident, and family to make alternative plans for further care. Indicate terminate services immediately if there is sufficient risk to staff or other residents determined by the administrator. Guys, it's my job to keep everyone safe in here. If there's a patient that's getting out of control, we have to remove them from this location. It's just not fair to the other patients or the staff members. Okay, I'll document all the facts that pertain to me. Well, our expectation is that the nursing will also do a lot of this documentation as well, which is the date and reason for termination of services, the name of the persons notified, date and method by which they are notified, name of the individual notified, resident's response, resident's condition, and then efforts made for continuity of care. Obviously, lots of documentation. We talk about the time of discharge or termination, about what we're going to do. We'll make sure that all the belongings, which there is a belonging form inside the patient chart that goes along with the resident's rights packet. It's the first page in there. So we know everything that the patient came in with before they even get into their bed. That way, it's just clear transparency across the board. Okay. It says here refund patients money due to them. That's an interesting statement there because a lot of our agreements are all with insurances and things like that. So there's nothing coming directly from the patient. And the way that we bill, it's normally post date. So it's after a certain amount of stay we bill for that time. So that's nothing that you guys need to worry about. The one thing that I do want to bring up is the AMA. So AMA, or discharging against medical advice, only applies when a resident expresses their wishes to be discharged earlier than outlined in the care plan. These situations do not apply if the facility offers to discharge a resident to a location which does not meet their health and or safety needs, and the resident agrees. The resident and family legal representative or family legal representative should be informed of the risks involved, the benefits of staying at the facility, and the alternatives to both. Under no circumstances will the facility force, pressure, or intimidate the resident into leaving AMA. We never do that. Anyone who's worked in the healthcare for any amount of time, the patient that's normally leaving AMA really shouldn't be going, but it's their right. It's their right to leave whenever they want. I know from working in acute care, especially inside the ED, that patients are in desperate need of these services and they just say, look, get me out of here. Get me out of here. For whatever reason it may be, they want to leave. We can't hold them. That's now abuse, right? We just talked about abuse. So physicians should be notified of the intended AMA discharge and be encouraged to speak with the resident to encourage them to stay at the facility. Documentation of this notification should be entered in the nurse's notes by the nursing department. The social services designee should document any discussions held with the resident family in the social services progress notes if present. That's going to be me. I'm going to do a lot of the transferring, or I'm going to do a lot of the documentation and the communication. And again, this is the policy and review test that we'll be going over. I know the answers are here. Don't mind that. Well, and again, just so everyone's on the same page, it's important for us here at this facility to know that you guys understand the concept. So when we see what is meant by an anticipated discharge, it's important for us to know that you guys know a discharge that is planned and is not due to the resident's death or emergency. Okay, these are not like super challenging questions, and if you miss one, it's okay. We'll go over it. I mean, we do have an expectation that you get 100% accuracy on these tests, but it's not going to be one of those types of situations where you haven't had an opportunity to review those questions because maybe you don't understand. Maybe I've misconstrued or I haven't conveyed the material in such a way that you understand it. So on that note, let's go ahead and get started with our PowerPoint, and we will finish from the PowerPoint to the residents' rights admission agreement. So we'll have plenty of time to go over that. So while we go through the PowerPoint, because I'm managing multiple screens and I'm trying to save whatever bandwidth we have, I'm going to kill the video. Okay, so this is our comprehensive review. 25 slides. We should get through this in the next 30 minutes or less, especially because we just did a review on our policy itself. So the purpose of this, the objectives, is to understand the purpose of residents' rights, to maintain the main categories of residents' rights, ways to support and promote residents' rights, and the facility's responsibilities. Okay. What is the purpose? All residents have rights guaranteed to them under federal and state laws and regulations. This legislation requires nursing homes to treat each resident with dignity and respect. We provide care to each resident in an environment that promotes and protects their rights. This regulation protects nursing home residents and provides for certain freedoms. Respect for resident rights is an important part of quality of care. Let's talk about the 8 categories that this can be divided into. Right to a dignified existence, right to self-determination, right of access to services, right regarding financial affairs, right to be fully informed, right to privacy, right during discharge and transfer, and rights to voice a grievance. So we do have a grievance plan and policy here. There is a form that if there's an issue where a patient is having a grievance, you fill the form out, it goes right into my mailbox outside my door or right outside Ray's door, and we answer them promptly. And we keep a record of them in case you guys are wondering. So dignified existence is that the patient is to be treated with consideration, respect, and dignity. Okay? Every patient has for us, we believe that God has made man in his image. So our fellow man and fellow woman that we have in this facility was created with a purpose, and they deserve every little bit of dignity that's owed to them. So we take this serious. We care that they have their individual preferences recognized and honored, that they are in an environment that's free from abuse, neglect, and exploitation. And a lot of these things will see that there is an overlap. There's an overlap amongst rights and abuse because we need them to have their rights to be free from abuse. So we'll give them a home-like environment and use of personal belongings whenever they can, have equal access to quality care, and have security of their personal belongings, which include freedom from involuntary searches of their body and possessions. That's not what we do here. That's not our job. In accordance with this right, residents have a choice of activities, schedules, and healthcare providers, including attending physicians. So again, we have one physician here on staff. His name is Dr. Alexander Chan. We do have an alternative. It's one of his NPs that follows him. As far as activities are concerned, we have an activities director whose job it is to find and place patients in appropriate level activities. We're not going to take a patient who's bedbound on a walk outside. We have to find things that match to their abilities based upon their care plan. And that's what we see here. Must receive reasonable accommodation of needs and preferences. Okay. They're encouraged to participate in developing and implementing a person-centered plan of care. Okay. Sorry, guys, my computer in the background is making some weird notes. They can choose to organize and participate in resident family groups, and they can request to refuse treatment if need be. Refuse and or stop. In accordance with this right, residents must have access to individuals, services, community members, and activities inside and outside the facility, visitors of his or her choosing at any time, and the right to refuse visitors, personal and medical records, his or her personal physician, and representatives from state survey agency and long-term care ombudsman. So we actually don't fall into the long-term care ombudsman. If there's an issue that a patient is having and you want to give them the licensing criteria on who they should contact, it would be CDPH. And that's lined out in the residents' rights admission packet that we have. And we'll also be giving them access to social, religious, and community events, and obviously if they need interpretive services. In accordance with the rights, can manage his or her own financial affairs. That's all on them. We don't have any say in what they do financially. Will be provided with information about available services and charges for each service, may have their personal funds deposited into separate interest-bearing account in their name and receive a quarterly as requested financial statement. We do not handle any patient's money. So this is nothing that you guys have to worry about, but this is information that's out there. We're still sharing it with you guys. And we obviously do not offer Medicare. Medicare is not someone that we're licensed with. So in accordance with this right, residents must be informed of and provide the type of care to be provided, as well as the risks and benefits of treatments, changes in their plan of care or their medical and health status, rules and regulations, including written copies of residents' rights, contact information for the ombudsman. Again, it should be or state survey agency here. I'm so sorry about that. It is in the residents' rights admission agreement pamphlet. Then we have a change of roommate in writing. We are a single patient room facility at this particular location. In the future, we may have one with, who knows? But right now, this is 18 single patient rooms. And information in language or manner he or she understands. Obviously, they have a right to privacy, includes personal, financial, and medical affairs, and unrestricted communication with any person of their choosing, and privacy during treatment and personal care needs. Okay, we're going to go over HIPAA too when it comes to these items that are here during the HIPAA video. So in accordance with this right, residents have the right to remain in the nursing facility unless their needs can't be met. Their health has improved. The safety of others is threatened. And they have a right to appeal proposed transfer. And we see all these things that you have exactly in our policy and procedure manual. Grievances. In accordance with this right, residents may voice grievances without discrimination, retaliation, or fear. We'll receive prompt efforts by the facility to resolve grievances. This is, and again, we're not going to make a claim with the ombudsman. Why don't residents always exercise their rights? And encourage residents and families to voice concerns. Some examples include on why they don't is they're unaware that they have these rights, they're uncomfortable, they have a difficulty voicing this, and they're worried about being labeled as a troublemaker. Okay. Ways that we can help with this is educate the resident and their families about their rights, provide residents with opportunities to exercise control, encourage residents and families to be involved and to discuss the concerns, and establish relationships between building staff and residents and their families. So things we can do to promote resident rights would be, or things that fall in this category are facility responsibilities, treating residents with dignity and respect, promote and facilitate self-determination, promote and facilitate privacy, report violation, and then we have lastly points to ponder. So we're going to treat all residents with respect and dignity. We've talked about this in great detail. Protect and promote resident rights, provide care in a manner and environment that promotes enhancement of his or her quality of life. We're going to provide equal access to quality care regardless of diagnosis or severity of condition or payment source. We're going to ensure residents can exercise their rights without interference. We're going to respect the resident's right to privacy and keep residents informed of all changes concerning care and health status. We're going to encourage and assist residents to dress in their own clothes instead of hospital gowns. We're going to make every effort that we can to that. We're going to place labels on the inside of the resident clothing and or shoes using a color coding system. So each patient's stuff will be limited inside their room. So that's our coding system, is that there is no cross-contamination. Promote resident independence and dignity while dining. We have a dining room, but we also allow the opportunity to people to eat inside their room if they like. We're going to knock on the door and ask for permission. Yes, we're going to promote independence and dignity. Yes, we're going to address residents by name and avoid using labels such as feeders or walkers. Yeah, that's terrible. Refrain from demeaning practices such as leaving urinary catheter bags uncovered or refusing requests for bathroom assistance during meal times. That's not good. Residents have a choice in activities according to their interests and preferences. Residents have a choice in their schedules, such as eating, bathing, bedtime, and waking time. Residents may participate in community activities both inside and outside the facility, and residents have a choice in offered healthcare options. We will, as far as facilitating privacy, we will provide resident privacy such as closing the door, pulling a privacy curtain, which all of our rooms are single patient, so there is no privacy curtain. We'll provide clothing or draping to prevent exposure of body parts during care, such as assistance with bathing and dressing. Only authorized staff directly involved with providing care should be present when care is provided. Ensure there are no signs that include clinical or personal information in the resident rooms that are visible to others. We're going to obtain consent before photographing and recording a resident and safeguard resident personal and medical records. So obtaining consent for photograph, we do photographing of the resident's wounds. So we can do staging and things like that. So consent will be performed, but we do take pictures in that matter. Now, there may be an event that we have here where the family members want to come in and we do like a bingo night or something like that. Some kind of event out, car show outside. That may be something that we have photos that are taken as well. So reporting violations are everything that's like an alleged violation of these is going to be reported to either myself or Raymond. And I would be technically designated as the abuse prevention coordinator. Okay. And what I'm going to do is I'm going to do an investigation and I'm going to have all these things written down, documented, and put inside the patient's chart, inside a grievance binder. So that way, if the state needs to get involved, they see a log of all the grievances. So a couple things to remember. All residents have rights guaranteed and protected by law. Care should be provided in an environment that promotes resident rights and enhances quality of life. Resident preferences should be included in all aspects of care that's in the care plan. If you suspect an alleged violation, speak up. We are very receptive to these things, okay? If you guys have any questions on this training, my recommendation would be to write them down. So when we do that pre-test, or I should say the post-test, that we are able to answer any of those questions you might have. Wow, doing a little bit of a strobe show over here. The last thing I want to show you guys is this standard admission agreement. And I'm going to open it up now and share it as well. So everyone is where in our facility, we have a 32-page document that comes from the CDPH 327 form. Now, we have made some modifications to this form for things that pertain directly to the congregate living health facility. We are a CLIF, okay? We are not a SNF, we are not an LTAC, we are not a hospital. So there are certain things that just didn't pertain to this. And so what we've made sure is that this particular document itself reflects who we are and what we do. You'll note that there's a table of contents, which goes through these various attachments that are here. You'll see that everything's filled out. And what will happen upon admission is these top things will get filled out. There will be places for the resident's family member or who they have designated to be their voice while they're here. All their information will be put in here. See where it says resident, resident's representative. And then here we have their insurance information and the list goes on. These are some of the services that we're going to be able to provide to the patients. And this is the resident's bill of rights. This is everything that matters to them. And this is all standard. This is from the state of California. the Residence Bill of Rights, and then we have a signature page. The signature page is like right in the middle of the document for the staff. But so you guys are aware, our policy, procedure, and practice. See, here's the page. It's on page 19 of 32. The admission packet that you see right here is going to be one of the first documents inside the patient chart. So if you ever were curious on, well, who can I reach out to this, or did the patient receive a a document that shows the rights that they have? Yes, they did. This is everything here. On that note, I am going to stop this video because we are done with residence rights. Trucking along, guys.